Welcome to our first video on environmental toxicities. Let's begin. In this lecture, we will be discussing anticholinergic poisoning and acetylcholinesterase inhibitor poisoning. For each of these topics, we'll discuss definition, pathophysiology, etiology, clinical presentation, diagnosis, and management. Let's begin by talking about anticholinergic poisoning. Anticholinergic poisoning occurs when a chemical substance inhibits the binding of acetylcholine to its receptors. This image serves as a reminder of the different types of receptors found in the autonomic nervous system. From this image, we can see that acetylcholine can bind two types of receptors, muscarinic receptors and nicotinic receptors. Both types of receptors are found in many different parts of the body. However, the key point to remember about them is that skeletal muscles have nicotinic receptors, not muscarinic receptors. Since substances with anticholinergic properties only work on the muscarinic receptors, skeletal muscles will be spared from the effects of the toxins. Remembering this key point will be useful in understanding the clinical features of anticholinergic poisoning. When acetylcholine binds to muscarinic receptors, it causes a parasympathetic response, which is normally activated when the body is ready to rest and digest. For example, when muscarinic receptors are activated in the heart rate decreases. When muscarinic receptors are activated on the intestinal smooth muscles, the motility of the gastrointestinal tract increases to aid in digestion. Inhibiting this parasympathetic process via poisoning causes an exaggerated sympathetic response. We will discuss the manifestations of anticholinergic poisoning in the next few slides. Importantly, anticholinergic substances inhibit the muscarinic receptors but have no effect on nicotinic receptors. Remember, nicotinic receptors are found on the neuromuscular junction. Therefore, these substances have little to no effect on the muscles. There are many substances that can cause anticholinergic poisoning. Many of these substances are medications. However, some plants can cause this type of toxicity as well. Let's go through some of the high-yield medications in plants that can cause anticholinergic toxicity. Any drug that inhibits muscarinic receptors as its primary mechanism of action can cause anticholinergic poisoning. Two examples of antimuscarinic drugs include atropine and scopolamine. Additionally, first-generation antihistamines such as diphenhydramine and cyproheptadine are very common substances that can cause anticholinergic toxicity. Another class of drugs that has been well described as having anticholinergic effects is tricyclic antidepressants. This is one of the many reasons why this class of antidepressants is not commonly used to treat depression. Some examples of tricyclic antidepressants are amitriptyline and imipramine. Some antipsychotic medications can cause anticholinergic toxicity as well. High-yield medications in this group include chlorpromazine and clozapine. Some inhaled bronchodilators dilate the airway primarily by inhibiting muscarinic receptors. This includes medications such as ipratropium and tiotropium. Some medications used to treat overactive bladder, including oxybutynin and tolterodine, function by inhibiting muscarinic receptors. Additionally, some drugs that are used to treat Parkinson's disease can also cause this type of toxicity. These medications include trihexyphenidyl and benztropine. There's a long list of plants that can cause anticholinergic poisoning. The most high-yield ones include Jimson weed and deadly nightshade. These two plants are commonly used for their hallucinogenic properties. Let's go through the clinical features of anticholinergic poisoning. These manifestations can be remembered by the mnemonic red as a beet, dry as a bone, hot as a hare, blind as a bat, mad as a hatter, full as a flask, and fast as a fiddle. Let's go through these in more detail and discuss the physiological processes that lead to these classical findings. Red as a beet refers to the skin flushing that occurs in people with anticholinergic toxicity. Skin flushing occurs because there is the inability to sweat, which leads to vasodilation to dissipate heat. Vasodilation, in turn, brings more blood to the skin, giving it a flushed or red beet-like appearance. Dry as a bone refers to the dry skin and mucous membranes that are caused by decreased sweating and mucus secretion. Hot as a hare refers to the patient's body temperature being high. The high temperature is a result of the patient being unable to sweat, which causes hyperthermia. Acetylcholine binding to muscarinic receptors has a role in eyesight, especially focusing on objects and accommodation. Thus, when acetylcholine is inhibited, the patient will be blind as a bat, meaning they will have blurry vision. The patient will also be mad as a hatter. This means that the patient can have anxiety, agitation, and visual hallucinations. The psychiatric symptoms occur because there are acetylcholine receptors in the central nervous system. The parasympathetic nervous system plays an important role in urination and digestion as well. When acetylcholine binds to muscarinic receptors in the bowel, this stimulates the bowel to digest food. Additionally, acetylcholine binding to muscarinic receptors on the bladder causes the detrusor muscle to contract so that the bladder can empty. Blocking acetylcholine in the bowel and bladder blocks these two processes, which will cause the patient to be full as a flask, meaning there will be urinary retention and constipation. Fast as a fiddle refers to the increase in heart rate that can occur in these patients. To understand this, remember that the vagus nerve is part of the parasympathetic nervous system, and it innervates the heart as well as many other parts of the body. The vagus nerve has acetylcholine receptors, and when acetylcholine binds to the receptors on the vagus nerve, the nerve causes the heart rate to slow down. So if acetylcholine cannot bind to its receptor on the vagus nerve, the nerve has less of an effect on the heart rate, leading to unopposed tachycardia. A 27-year-old woman is brought to the emergency department due to hallucinations and confusion for 24 hours. Her boyfriend found an empty bottle of pills next to her. She has a history of peptic ulcer disease and schizoaffective disorder. Her regular medications include omeprazole, chlorpromazine, and sertraline. The physical exam reveals flushed skin and mydriasis, overdose of which medication most likely accounts for this patient's current symptoms. This patient presents with hallucinations and confusion after a possible suicide attempt. She has a history of peptic ulcer disease and schizoaffective disorder. Her regular medications include omeprazole, chlorpromazine, and sertraline. Physical exam reveals flushed skin and mydriasis. Altered mental status and psychosis along with these physical signs are consistent with anticholinergic toxicity. The only medication from this patient's list that has the anticholinergic properties is chlorpromazine. Therefore, chlorpromazine overdose most likely accounts for her current symptoms. Diagnosing anticholinergic poisoning is typically based on the clinical signs and symptoms that we discussed in the previous slides. Additionally, if physiostigmine, an acetylcholinesterase inhibitor, reduces the symptoms, this suggests the diagnosis. When treating this condition, the most important thing to do initially is to stabilize the airway and manage breathing and circulation. Clinician would also want to establish intravenous access and administer oxygen to the patient. Cardiac monitoring and pulse oximetry are also very important since this type of poisoning significantly affects the heart and lungs. The reversal agent that is used to treat anticholinergic poisoning is called physiostigmine. This drug inhibits acetylcholinesterase, which is the enzyme that normally degrades acetylcholine in the synapse. By inhibiting this enzyme, the levels of available acetylcholine increase, which in turn dampens the effects of anticholinergic poisoning. It's important to remember that physiostigmine can cross the blood-brain barrier, which means it will also improve symptoms of agitation, hallucinations, and other psychologic manifestations. Let's take a closer look at how physiostigmine can treat anticholinergic poisoning. In this illustration, we see acetylcholine binding to a muscarinic and nicotinic receptor. On the top right, you can see that muscarinic antagonists inhibit acetylcholine from binding to the muscarinic receptors. In this image, we also see acetylcholinesterase, which breaks down acetylcholine in the synaptic cleft. Physiostigmine functions as an inhibitor of acetylcholinesterase, which leads to an inability to break down acetylcholine and a higher concentration within the synapse. Once the concentration of acetylcholine increases inside the synapse, this overcomes the inhibition of the muscarinic antagonists. An 89-year-old woman is brought to the emergency department due to confusion for the past 12 hours. She took scopolamine before a boat trip due to her motion sickness. Her vital signs are significant for a temperature of 39 degrees Celsius and a heart rate of 120. The physical exam reveals flushed skin. After initial resuscitation, which medication can definitively reverse her symptoms? This elderly woman presents with confusion, hyperthermia, tachycardia, and flushed skin after taking scopolamine. Scopolamine is an anticholinergic agent used to treat motion sickness. Therefore, this patient likely has anticholinergic toxicity. The medication that can definitively reverse her symptoms is physiostigmine. Physiostigmine is the acetylcholinesterase inhibitor with high blood-brain barrier permeability. Therefore, it increases the acetylcholine levels in the synaptic clefts. Acetylcholine then displaces the anticholinergic medication from the muscarinic and nicotinic receptors, reversing the patient's symptoms. Next, we'll move on to talk about acetylcholinesterase inhibitor poisoning. This is poisoning with an agent that inhibits acetylcholinesterase, which is an enzyme that breaks down acetylcholine. Inhibiting acetylcholinesterase causes acetylcholine to bind up at muscarinic and nicotinic receptors. Since nicotinic receptors are affected, skeletal muscles are affected in this type of poisoning. We will illustrate this in the next slide by taking a look at the basic layout of the autonomic nervous system. If you look back at our image depicting the basic layout of the autonomic nervous system, once again we see that there are muscarinic and nicotinic receptors throughout the body, and that nicotinic receptors are located on skeletal muscle. Acetylcholinesterase inhibitors increase levels of acetylcholine in the synapse, allowing more acetylcholine to bind to both muscarinic and the nicotinic receptors. This means that unlike acetylcholinergic agents, acetylcholinesterase inhibitors will also have an effect on skeletal muscle. This image demonstrates how acetylcholinesterase inhibitors raise levels of acetylcholine in the synaptic cleft. You can see here that acetylcholinesterase normally breaks down acetylcholine. Therefore, when acetylcholinesterase inhibitors block acetylcholinesterase, the amount of acetylcholine in the synapse increases. The increase in acetylcholine overstimulates the muscarinic and nicotinic receptors, leading to the many clinical features of this poisoning. There are two main categories of substances that can cause this type of toxicity. Pesticides are a common culprit because they contain chemicals known as organophosphates. Organophosphates are absorbed into the body in several ways, including through the skin, lungs, and gastrointestinal tract. These organophosphates then inhibit acetylcholinesterase and lead to excess acetylcholine in the synapse. There are also several medications that primarily work by inhibiting acetylcholinesterase and can lead to manifestations of acetylcholinesterase toxicity. Some of the common drugs that do this include pyridostigmine and donepezil. Pyridostigmine is commonly used to treat myasthenia gravis, and donepezil is a common drug used to slow the progression of Alzheimer's dementia. The net effect of acetylcholinesterase inhibitors on the autonomic nervous system is an exaggerated parasympathetic response. Manifestations in the autonomic nervous system can be remembered by the mnemonic sludge BBB. This is the mnemonic that is used to remember the manifestations of acetylcholinesterase inhibitor poisoning on the autonomic nervous system. Let's go through this mnemonic in detail. S stands for salivation, and L stands for lacrimation, both of which occur because acetylcholine stimulates the salivary glands and also stimulates production of tears. U stands for unintended or excessive urination, which occurs as a result of detrusor muscle overstimulation by acetylcholine. D stands for unintended or excessive defecation, and GE stands for gastric emesis, both of which occur because acetylcholine stimulates smooth muscles of the digestive tract, which increases their motility. The three B's stand for bronchorrhea, bronchospasm, and bradycardia. Bronchorrhea means production of excess sputum, and it occurs because acetylcholine stimulates production of secretions in the airway. Bronchospasm is caused by acetylcholine causing the smooth muscle in the walls of the bronchioles to contract. Bradycardia results from excess stimulation of the vagus nerve, which, when stimulated by acetylcholine, slows down the heart rate. Remember that all these findings are a result of heightened parasympathetic response in the setting of abundant acetylcholine in the system. Remember that acetylcholinesterase inhibitors function at both nicotinic receptors and muscarinic receptors. Since nicotinic receptors are affected, chemicals that inhibit acetylcholinesterase will have an effect on skeletal muscles. Overstimulation of nicotinic receptors on skeletal muscles by acetylcholine impairs the patient's ability to control the muscle, which may manifest as fasciculations, muscle weakness, or paralysis. Diagnosis is usually based on clinical signs and symptoms. However, some things can be assessed to support the diagnosis. One test that can be performed is a measurement of the red blood cell acetylcholinesterase activity. If the activity is low, this could indicate that the patient has acetylcholinesterase inhibitor poisoning. The diagnosis can also be supported if a trial of atropine reduces symptoms. To understand the reasoning behind this, remember that atropine prevents acetylcholine from binding to its receptor, thereby decreasing the effects of acetylcholine. If the patient has acetylcholinesterase inhibitor poisoning, their symptoms are caused by an excessive amount of acetylcholine in the synapse. Therefore, treating them with atropine, which prevents acetylcholine from binding to its receptor, will prevent overstimulation of acetylcholine receptors and dampen the parasympathetic response. A 79-year-old woman with Alzheimer's dementia is brought to the emergency department by her daughter due to shortness of breath, vomiting, and excessive drooling. Her regular medications include donepezil and memantine, but the patient does not remember how many pills she took today. The patient's underwear is soiled. Her vital signs include a heart rate of 50 beats per minute. The patient is promptly treated with an antidote. Which test can support the diagnosis of this patient's condition? This elderly woman with Alzheimer's dementia presents with shortness of breath, vomiting, and excessive drooling. Her underwear is soiled. Her vital signs include a heart rate of 50 beats per minute. Hypersecretion and bradycardia suggest poisoning with an acetylcholinesterase inhibitor. This patient takes donepezil, an acetylcholinesterase inhibitor, and she does not remember how many pills she took today. Therefore, she likely overdosed on donepezil. Acetylcholinesterase inhibitor poisoning is a clinical diagnosis and does not typically require further diagnostic investigation. However, one can measure RBC acetylcholinesterase activity in order to support the diagnosis of this patient's condition. One of the first steps in treatment is decontamination. This means removing the clothing that may be contaminated and rinsing the skin to prevent further absorption. It may be necessary to perform endotracheal intubation to maintain adequate ventilation, especially if the patient has central nervous system depression. Importantly, one should avoid using succinylcholine when intubating patients with this type of poisoning. Succinylcholine is a paralytic agent that is commonly used during intubation. It's normally broken down by acetylcholinesterase, which is inhibited in these patients. As a result, these patients will be slower at metabolizing succinylcholine and may sustain a longer period of paralysis as a result. The drug regimen that is used to treat acetylcholinesterase inhibitor poisoning is atropine plus pralidoxime. First, it's important to remember that acetylcholinesterase poisoning affects both muscarinic and nicotinic receptors. Atropine is given to counteract the poison at muscarinic receptors, but it won't have any effect on the nicotinic receptors. Pralidoxime, on the other hand, will address the problem at both muscarinic and nicotinic receptors because it will increase the levels of acetylcholine by reactivating and restoring the function of acetylcholinesterase. A very high-yield point is that the provider should always administer atropine before pralidoxime. This is because pralidoxime transiently inhibits acetylcholinesterase when administered. This causes more acetylcholine buildup in the synapse, which worsens symptoms. Since atropine blocks the muscarinic receptors, it will counteract the transient acetylcholinesterase inhibitor effects of pralidoxime. Therefore, the atropine should be given first so that the transient buildup of acetylcholine in the system from pralidoxime will not negatively impact the patient. A 57-year-old farmer presents to the office with shortness of breath. He was working in the fields when he suddenly felt short of breath. He has vomited twice on his way to the clinic. The patient is sweating profusely. His underwear is soiled. The vital signs are significant for a heart rate of 53 beats per minute. Atropine is given, followed by pralidoxime. What is the most likely rationale of administering atropine before pralidoxime? This farmer presents with shortness of breath due to possible bronchospasm, vomiting, sweating, and bradycardia. The signs of hypersecretion along with bradycardia suggest the acetylcholinesterase inhibitor poisoning. Given his occupation, this patient is likely suffering from organophosphate poisoning. Atropine is given, followed by pralidoxime. The reason for this specific sequence is that pralidoxime initially causes a transient inhibition of acetylcholinesterase. Therefore, acetylcholine builds up in the synaptic cleft and worsens the symptoms. Since atropine blocks the muscarinic receptors, it will counteract transient acetylcholinesterase inhibitor effects of pralidoxime at the muscarinic sites. Here is a summary slide containing many of the high-yield facts about the types of poisonings that we've discussed. Let's conclude this lecture with a board-style question. A 55-year-old woman presents to the emergency department due to vomiting and diarrhea for 5 hours. Her past medical history is significant for chronic alcoholism and medically treated myasthenia gravis. She has been admitted for methanol and ethylene glycol poisoning 7 and 10 years ago, respectively. This morning, the patient took twice the dose of her myasthenia gravis medication due to excessive weakness. Her vital signs include a temperature of 37 degrees Celsius, blood pressure of 110/80, heart rate of 49. Physical exam reveals meiosis, excessive salivation, and bilateral wheezing. Lab studies are unremarkable. Which of the following is the best initial treatment option for this patient? A. Atropine. B. Glucagon. C. Fomepizole. D. Physostigmine. This patient with myasthenia gravis presents with vomiting and diarrhea. The physical exam reveals meiosis, excessive salivation, and bilateral wheezing. Signs of hypersecretion along with bronchospasm suggest an increased acetylcholine activity. This morning, the patient took twice the dose of her myasthenia gravis medication due to excessive weakness. Myasthenia gravis is treated with pyridostigmine, an acetylcholinesterase inhibitor. Therefore, this patient has an acetylcholinesterase inhibitor poisoning. This diagnosis is further supported by bradycardia with a heart rate of 49 beats per minute. The best initial treatment option for acetylcholinesterase inhibitor poisoning is atropine. Atropine reverses the acetylcholine effects at the muscarinic receptors. Therefore, the correct answer is option A. Here's a slide comparing and contrasting the different types of poisoning. This patient with acetylcholinesterase inhibitor poisoning from physostigmine will be treated with atropine followed by pralidoxime. Let's discuss why other options are incorrect. Option B is incorrect because glucagon is typically used for the treatment of beta blocker overdose, not acetylcholinesterase inhibitor poisoning. Option C is incorrect because fomepizole is used to treat methanol and ethylene glycol poisoning. Although this patient has past history of methanol and ethylene glycol poisoning, she has no physical signs or laboratory derangements suggesting these conditions now. Finally, option D is incorrect because physostigmine treats the anticholinergic toxicity. It does so by increasing the acetylcholine levels in the synaptic clefts. Therefore, giving physostigmine to this patient would further worsen her symptoms. And that concludes the section.